When the brain misfires, seconds matter. And honestly, what you do not do is just as heavily tested on the NCLEX as what you actually do. I want you to picture the human brain as a highly complex electrical grid. Now, imagine a massive, unpredictable lightning storm striking that grid, just throwing the entire system into chaos. That's exactly what a seizure is. It's a neural storm. And as a future nurse, your job is to guide the patient safely through it.
So, to really master this explainer for your exams and, your future clinical practice, we aren't just going to memorize a bunch of meds. You absolutely need to know those glaring red flag contraindications that can literally mean the difference between life and death for your patient. Let's dive right into exactly how this storm starts. Okay, so what exactly is happening during this storm? Let's look at the pathophysiology. A seizure is an abnormal, excessive, and hypersynchronous electrical discharge of neurons in the brain. Basically, it's a super dangerous imbalance. Normally, your brain maintains this really delicate balance between exciting neurons to send signals and inhibiting them to keep things calm and orderly. But during a seizure, that excitation just completely overwhelms the inhibition. A group of neurons starts firing excessively and all at once, in this perfect, chaotic sync. Now, we classify this electrical storm based on where it strikes and how it spreads. First up, we've got focal seizures. Just like the name implies, the storm stays localized to one specific area of the brain. The patient might retain their awareness or they might lose it, but the electrical chaos remains contained. On the flip side, we have generalized seizures. This is when the storm rapidly spreads across both hemispheres, the entire brain. You'll typically see this as an absence seizure, which is a brief staring spell often seen in kids, or the classic, highly tested tonic-clonic seizure. All right, let's walk through the exact chronological timeline of a generalized tonic-clonic seizure, because you really need to recognize these signs instantly on the floor. First off, some patients experience an aura. This is a sensory warning, like a strange smell or a visual change, right before the seizure hits. Then comes the tonic phase, marked by sudden, severe muscle stiffening and a total loss of consciousness. This immediately transitions into the clonic phase. This is the rhythmic, violent jerking of the body. During this intense muscle contraction, incontinence and tongue biting are incredibly common. Finally, once the electrical storm passes, the patient enters the post-ictal phase. They aren't going to just wake up and say hello. They will be profoundly confused, fatigued, and incredibly sleepy as their brain tries to recover. Understanding that intense physical manifestation brings us to the single most critical NCLEX trap you will ever face. When a patient is actively seizing, there are two massive, glaring red flags. You need to burn this into your brain. Do not restrain the patient, and do not put anything in their mouth. I literally cannot emphasize this enough. If you try to hold down a convulsing patient, you will cause bone fractures and severe injury. And if you force a padded tongue blade or anything else into their mouth, you're going to break their teeth, obstruct their airway, and create a severe choking hazard. Your job is not to physically stop the movements. Instead, your core job is to create a soft, safe space around the patient. Let's look at our priority nursing interventions. Step 1, protect and position. Ease them to the floor if they're sitting, protect their head with a pillow or a blanket, loosen any tight clothing, and immediately turn them side-lying. Why? Because side-lying prevents aspiration of saliva or vomit and keeps that airway open. Step 2, never leave them. Stay with the patient and, critically, time the seizure. Step 3, after the movements stop in that post-ictal phase, maintain the airway. This is when you use suction and oxygen as needed. Step 4 involves recognizing if the seizure won't stop, which triggers emergency status epilepticus protocols. And Step 5, implement seizure precautions for the future, like keeping the bed low, padding the side rails, and having suction and oxygen ready at the bedside. Okay, time to test yourself. Let's see how well you've locked this in. Question 1. A client begins to have a generalized tonic-clonic seizure. What is the nurse's priority action? Is it A, turn the client to the side and protect the head from injury? B, insert a padded tongue blade into the mouth? C, restrain the client's arms and legs? Or D, hold the client down until movements stop? Drop your answer in the comments right now. 3, 2, 1. Boom, the correct answer is A. You always turn the client to the side to protect the airway and ensure the head is protected from trauma. As we just learned, the rationale is crystal clear here. Sideline positioning prevents aspiration, which is actually one of the main things that kills the patient. You place absolutely nothing in the mouth, and you never, ever restrain them. Safety and the airway are always your absolute NCLEX priorities. Now, knowing what to do when a typical seizure becomes a life-threatening crisis is absolutely crucial. This brings us to status epilepticus. I really need you to shift into high alert right here.
Status epilepticus is defined as continuous seizure activity lasting more than 5 minutes, or repeated back-to-back seizures where the patient does not recover consciousness in between. This is a massive medical emergency. If that neural storm doesn't stop, the brain is deprived of oxygen. A prolonged storm leads to severe hypoxia, permanent brain injury, and ultimately death if it's not aborted immediately. When you identify status epilepticus, your emergency pharmacology sequence literally has to be lightning fast. Your absolute first line of defense is an IV benzodiazepine, typically lorazepam or diazepam. You use these fast-acting meds to extinguish the fire. They act rapidly to abort the active seizure. Then, once the immediate fire is out, you move to your second line. You need to load the patient with an anti-epileptic drug, or AED, like phenytoin or levetiracetam. The benzo stops the current storm, and the AED loading dose prevents the storm from coming right back. Let's put that emergency knowledge to the test real quick. Question 2. A client has had continuous seizure activity for 7 minutes without regaining consciousness. The nurse recognizes this as status epilepticus and anticipates administering A. Oral phenytoin, B. IV lorazepam, C. Acetaminophen, or D. A saline bolus only. Think fast, drop your answer below. 3, 2, 1. And the correct answer is B. IV lorazepam. In this incredibly high-stakes scenario of status epilepticus, oral medications are completely useless because the patient is unconscious and actively seizing. And a simple saline bolus? That won't stop the brain from misfiring at all. IV benzodiazepines like lorazepam are your immediate, first-line lifesavers to stop that prolonged, dangerous seizure activity and prevent irreversible brain injury. Speaking of anti-epileptic maintenance drugs, there's one critical number you just have to memorize for phenytoin: 10 to 20 micrograms per milliliter. That is its highly tested therapeutic range. If the drug level in the blood drops below 10, it's subtherapeutic, and the patient is at a huge risk for breakthrough seizures. If it goes above 20, they risk severe toxicity. Oh, and here's a massive clinical pearl for your exams. When you are administering IV phenytoin, it must be given slowly, and it must be mixed with normal saline only. If you mix it with dextrose, it will literally precipitate and crystallize right there in the IV line. No way do we want that. Now, as we wrap up our patient teaching, here's a strict, non-negotiable warning that you must pass on to your patients. Never, ever stop anti-epileptic drugs abruptly. You must teach your patients that they have to take their AEDs exactly as prescribed. Stopping these medications suddenly is the #1 most common trigger for rebound seizures and, worse, throwing the patient right back into a status epilepticus emergency. Medication adherence is absolutely everything when living with a seizure disorder. Master seizures by remembering this core mantra: protect the airway by turning them to the side, absolutely do not restrain them, and remember, it's an IV benzo first for status epilepticus. But hey, here's something to think about. If a seizure is an electrical storm in the brain, what happens when a patient is paralyzed for surgery and we literally can't see the physical convulsions? Well, we'll tackle hidden neuro emergencies next time. If this made it click, subscribe. One killer med-surg topic every day until you pass the NCLEX.